Cryopreservation has been a fundamental tool in assisted reproduction. The protocol for embryo freezing was standardized in the early 80s. However, when it comes to oocyte, it was much more challenging because insufficient results were consistently produced until barely a decade ago when we introduced vitrification. The initial failure obeys to a variety of reasons, but I would say that the main reason is the oocyte itself, because this is a large cell, very sensitive to chilling injury and much more prone to ice formation. The reasons for the striking success of vitrification lie essentially in its ability to prevent ice formation. Today, we count on a variety of tools and methods for vitrification as a result of the hard work of notable cryobiologists to produce the successful protocols we have these days. We introduced vitrification in our ovum donation program in 2007 with the aim of validating the technology for its later introduction in the routine clinical practice. So initially, we studied the embryo quality produced with vitrified oocytes, but it was later in 2010 when we proved the efficiency of vitrification within a randomized clinical trial. In this trial, we showed comparable outcomes between fresh and vitrified donations. Since then on, oocyte vitrification has been widely used in many IVF centers worldwide, not only for ovum donation with the clear benefits as easier logistics and the possibility of safeguarding the quarantine period, but also it's been used in infertile patients and in women seeking for fertility preservation. So fertility preservation is today a reality thanks to vitrification. This is a quite new discipline in assisted reproduction, which brings women the opportunity to save their fertility for the future. This is mostly useful in a particularly sensitive population of cancer patients needing potentially gonadotoxic treatments, or for women who wish to delay motherhood for different reasons. We have learned some useful lessons during 10 years of applying elective fertility preservation, and today we can say that vitrification provides a means to increase the chance of having a biological child. But these chances depend on the age and the number of oocytes vitrified. We have observed a systematic reduction in success rates as the age increases. The calculation of cumulative live birth rates according to the age and the number of oocytes used by a patient is a very useful tool for gynecologists in order to counsel women seeking for fertility preservation. So finally, we can say that today vitrification is a consolidated technology that has meant a breakthrough in our field, not only to treat infertile patients, but as a way available to modern women to help them to continue with their professional and personal development with the probability of safeguarding their chances of having a child in the future whenever they decide. And we can proudly say that with our work, we have helped this come true.